Right, welcome everybody. Hello, welcome to Durban, South Africa. And thank you for joining us on this talk on the one platform system, ALLIUM stents, especially we're going to discuss the stents, the options for you. Once again, my name is Shiven Ramkissoon and I'm a urologist from South Africa. Just a little bit about me. Yeah, as Maxime mentioned, I'm from Durban, which is probably the most amazing piece of the planet on the east coast of South Africa, not the west coast, as Maxime said.
East coast, right.
We're well reputed and
yes.
Yeah, that's right. We're well renowned for our 12 months of summer.
Is on the west.
As you can see, this is our, yeah, that's right, but we don't know where Cape Town is in Durban. Yeah, this is our winter activities here in South Africa. And you'd notice that we get as much of an adrenaline rush from our outdoor activities as we do in our theaters here in Durban. So yeah, if you guys are here anytime soon, please give us a shout. We'd be more than happy to welcome you and host you on our lovely, beautiful shores. Just a little bit more about me. I quite enjoy long distance cycling and I've done a few of our races here locally. And I quite fancy myself as a cricket player of note, although this picture of Joe Root striking a pose is pretty much like online shopping, where the finished product doesn't necessarily reveal what you've got on screen. Socially, or rather personally, I'm married with 2 kids, and my wife's also in the medical profession. She's a specialist pulmonologist. All right, jumping straight into the talk. We're going to outline the scope of the talk. Okay, firstly, we're going to discuss and outline the use of stenting of the lower urinary tract. And we're going to look at the options ALLIUM has to offer with regards to stenting the lower urinary tract. And I'm going to share my experiences with you towards the end of this talk. We're going to do all of this in about 30 to 35 minutes. And I'm happy to take questions at the end. Okay, jumping straight into the talk. Obstructive lower urinary tract symptoms are quite common, and they may be due to a variety of conditions, either anatomical or functional disorders, as we see in neurogenic bladders. Currently, there are a variety of good quality treatment options available, like medical options for the treatment of benign prostatic hyperplasia with alpha blockers, and surgical disc obstruction. The option of stents in the lower urinary tract offers a viable, minimally invasive treatment option in the well-selected patient. And this may obviate the need for more invasive surgery or even remove the need for frequent interventions. Okay, if you look at the clinical benefits of stenting in the lower urinary tract, specifically the ALLIUM stents, the stents are fairly safe with the easy placement and removal. The radiopaque markers allows us to place it in a reasonably reliable position on fluoroscopy. The stents are designed to prevent tissue ingrowth and reduce incrustation and hyperplasia. They consist of a which is made of silicone and polyurethane, and a nitinol sort of wire around it, which gives it its tensile strength. The stents are designed to be in for up to 3 years and results in improved quality of life. They're also a cost-effective solution or by grasping on the tip, the entire thing unravels and the stent can be removed sort of with the wire intact. Okay, if you look at the ALLIUM to treat strictures in the bulbar urethra. Right, just to remind us of the anatomy of the bulbar urethra. Basically, this is the portion of the urethra from the sphincter, the membranous urethra, all the way to the penile urethra. The ALLIUM BUS stent would address strictures throughout the bulbar urethra, and they're sort of being soft and flexible, follow the anatomical contour of the bulbar urethra. We'll discuss the shape and size of the stents a bit later, and we'll look at our preferences. And I think with regards to stent placement, I think each surgeon will probably develop his own preference with regards to which size he'd use. All right, this is an X-ray that shows us, just to orientate you, this is the patient's bladder and neck, the prostatic urethra. We're at the level of the sphincter. And here we have a stricture in the bulbar urethra, about 1 centimeter to 1.5 centimeters, about 2 centimeters from the sphincter. So this slide demonstrates the management of the stricture with a BUS stent. So basically this patient has had a cold knife ureterotomy and the stent has been placed with a tapered end close to the sphincter. And you can see there's a good result here with wide patency and good flow of contrast through there. Okay, the clinical indications for these stents are bulbar urethral stenosis. They could be considered as an alternative or a bridging to a urethroplasty. and may prevent the need for recurrent ureterotomies. It's important to bear in mind that the stent is a single-use device, and it's intended to remain in the urethra for up to 3 years. We mentioned that they come in a variety of sizes, either the 50, the 60, the 80, and the reverse 80 stent. I'll touch on this a bit later, but the reverse 80 has become my preference of late, and I'll mention why in subsequent slides. All these stents we mentioned are distensible. They're fairly soft, as you can see here, and fairly well tolerated by the patient. Okay, the main function of the stent is to maintain patency and allow for excellent flow through it. More importantly, these allow scar tissue to form around it. So when removed, we remaining in that wide open position. Okay, I'm not going to run through all of this, but to choose the correct stent size, we would need to look at the stricture length and the distance from the sphincter. So if we take, for example, a stricture which is 3 centimeters long and about 2 centimeters from the sphincter, we should consider using the 60 millimeters. My preference, however, for the bulk of the strictures in the bulbar urethra is to use the reverse 80. And I mentioned we'll go through that a bit later, and I'll show you slides and pictures as to why I prefer this. Okay, so the buzzword right now, this pandemic that's going around, and where ALLIUM BUS stents would fit in. Currently in South Africa, we've experienced theatre shutdowns. We're at this stage right now where we sort of recovering from theatre shutdowns where only emergencies and fairly urgent cases were being done. With opening up of our theatres, we're anticipating long waiting lists and an overburdened system. So ideally, we should be looking at more efficient ways of using our theatres and treating our patients as well, both by minimizing the duration in hospital and also trying and minimizing the hospital admissions as well. The ALLIUM long-term stents will help us support and achieve these goals by obviating the need for recurrent ureterotomies and also taking away the need for patients to stay for prolonged hospital stays with urethroplasties and get our patients as functional as soon as possible as well. So it's an important tool to consider in our armamentarium. Okay, if you look at the benefit of the ALLIUM stent over repeated ureterotomies, these stents have a 3 years indwelling time, and they're fairly well tolerated by the patients, and with good reported patient comfort. This can be done as an outpatient procedure. The patient can literally go home the same day. The stents are reversible, they are highly efficacious, and have a pretty short recovery time, none of which is seen with repeated ureterotomies. Okay, just to touch on the triangular prostatic stent. Okay, these stents are indicated for the management of benign prostatic hyperplasia or bladder outlet obstruction seen in adult males, largely due to BPH. One should bear in mind this as a treatment option for patients who have voiding difficulties or retention post minimally invasive treatments of the prostate, as in prostate brachytherapy, cryotherapy, hot water thermotherapy, laser coagulation surgery, microwave thermotherapy, and radiofrequency therapy. These stents are also single-use devices and are also intended to remain in the urethra for up to 3 years and also distend to a maximum of 45 French caliber. All right, this slide neatly demonstrates why these stents are triangular. And I think if we recall the anatomy of the prostatic urethra, it's actually triangular in configuration, not round like the rest of the urethra. So the triangular design allows more anatomical apposition with less tissue ingrowth and less irritation of the prostate as well. And there's a less likelihood the stent would migrate. Here we can see that radiologically, the stent is placed with the proximal end at the bladder lip, the body in the prostatic urethra, the tapered segment approaching the verumontanum, a transsphincteric portion traversing the membranous urethra, and an anchor in the bulbar urethra. So we mentioned that these stents are used predominantly in the treatment of benign prostatic hyperplasia, and it can be used as a bridge to surgery instead of a prolonged indwelling catheter. The pretty much niche position or role for these TPS stents would be in patients who are high risk for surgery, as this can be done under sort of sedation or even local anesthetic as well. I think it's important to keep this in mind as a tool for your intraoperative management of patients with benign prostatic hyperplasia. Okay, choosing the correct stent size. The stents basically come in 4 sizes, the 30, 40, 50, and the 60. The key to your stent selection would be accurate measurement from bladder neck to verumontanum. And you can do this by the gratings on the cystoscopy or using a ureteric catheter. And depending on your length, you would choose the appropriate size. Okay, placements of these stents fairly simple. Using a one platform system under direct vision, you'd insert your device all the way to the bladder neck, and you'd keep yourself, and you'd rather keep the device there, keep yourself stationary, and activate the trigger until the stent has released itself from the device. And then you wait 4 to 5 minutes. It's important that you're patient and you wait for a sufficient amount of time before withdrawing the device. You can remove the stent with. On removal of the device, you make a gentle rocking movement to remove it, and there should be no vigorous or harsh movements. Okay, these stents can also be placed under X-ray, and to do this, you'd mark the level of the bladder neck at cystoscopy, and then you'd mark the level of the sphincter, and basically deploy the stent using the markers on the stent to sit between the bladder neck and the level of the sphincter. Okay, a few tips and tricks with inserting these stents. We mentioned that important, or rather the measurement is key. And to get the accurate measurement, you must take the measurement from the bladder neck all the way down to the verumontanum. These stents can be protruded slightly into the bladder, and just sort of, superior to the bladder neck up to about 0.5 centimeters. The anchor should be placed in the correct position in the barber urethra. It's important that you measure correctly, so you choose the appropriate stent size. A short stent may result in residual obstruction, and a long stent may result in the patient being incontinent. Also, be patient when applying these stents or when inserting these stents, especially when removing the device. Take your time, allow sufficient time for the stent to distend or to sort of open up, and you remove it fairly slowly. When inserting these stents, one should consider inserting a suprapubic catheter, largely because this prevents the flow of urine through the stent for the first 2 to 3 days, which would lessen the chance of migration. And also, patients who have established benign prostatic hyperplasia often have this dysfunctional pattern of voiding where they either or use abdominal augmentation of their voiding. The suprapubic catheter in these instances would lessen your chance of migration of the stent. Okay, and the last stent that we have in the lower urinary tract, the last ALLIUM stent we have is the round prostatic stent. Round posterior stent, sorry, schoolboy error there. Okay, so the RPS in a nutshell, basically, I'm going to use a case here to demonstrate how it works. So if we look at this patient, he's got a bladder neck contracture following a radical prostatectomy. This was opened up with a blazer, and basically the round posterior stent, as you can see on this diagram, is inserted across the contracture, and pretty much like the TPS, with the sphincteric portion across the membranous urethra and an anchor in the barber urethra. And here you can see, radiologically, there's good resolution of your contracture, and there's good patency with good flow. So we mentioned that these stents are used in the indication of bladder neck contracture, or rather indicated for the use of for treatment of bladder neck contractures and posterior urethral strictures, which are commonly seen post-radical prostatectomy and after TURP. Following radical prostatectomy, you need to consider possibly the use of an artificial urinary sphincter in these patients as well, as they often have a damaged sphincter. Okay, if you look at the specifications of these stents, they pretty much all have a body, transsphincteric portion, which is 20 millimeters, and an anchor, which sits in the barber urethra. And anatomically, pretty much like the TPS stent, they sit from the bladder neck all the way down to your verumontanum with the transsphincteric portion and the anchor in the barber urethra. Okay, choosing the correct stent size is important as well. And once again, accurate measurement is key here. And once you've chosen your correct stent size, basically the stent would sit across the contracture, all right, and with the anchor sitting in the barber urethra. All the stents, all the round posterior stents, to stand up to 45 French, just like the TPS and the BUS as well. Okay, the tips and tricks in inserting these stents, pretty much the same as the TPS. You've got to be patient when inserting it. Keep yourself still when deploying the mechanism. Wait a sufficient amount of time before withdrawing the one platform system mechanism from the patient. And consider suprapubic catheter as well. Okay, so just touching on the options of, or the ALLIUM options of stenting in the lower urinary tract, I'm going to basically touch on my ALLIUM experience. And there's a reason why the slide is sort of configured with the ureteric ALLIUM taking up the lion's share of the slide, and the barber, so the BUS here pretty much in the background. And that's because I've done far more ureteric ALLIUMs than I have BUS. before we jump into my experience, basically we have limited access to theater time, both us as surgeons and our patients as well. The cost of medical treatment is always at the back of our mind when we approach our patients, both in the private and the public sector. Patient compliance is not always ideal here. We're inundated with concomitant third world diseases, which adds a span in the works and a different spin on things as to how we do things here, because patients presenting with these problems may present with urgent issues, which would prioritize their cases over less important things. And also, the bulk of the strictures that we see tend to be sexually transmitted related diseases as well. Our patients often tend to present late, and that's something to bear in mind as well when managing these patients. So we tend to see extremes of conditions, and the bulk of our population still sadly has poor access to healthcare. Okay, so if we look at, bearing in mind some of the constraints that we just mentioned, if we look at the possible benefits of low urinary tract stenting in our setting, these may provide a viable alternative to repeated ureterotomies, as the patient has basically two procedures, one for the insertion and one for the removal. So this would lessen the burden in theater, and also it provides to be a cost-effective solution. It also provides a definitive stricture management solution, unlike ureterotomies, which is pretty much addressing the problem at that point in time. Urethroplasties require a certain amount of expertise and should ideally be done in a center of excellence. And also the cost here may be prohibitive. The ALLIUM stents in the lower urinary tract can alleviate our theater burden and also reduce our waiting lists. Okay, so as we mentioned, I've done far more ureteric ALLIUMs than I have lower urinary tract ALLIUMs. Done around 30 ureteric ALLIUMs. The indications for these have been calculus-associated strictures, inflammatory strictures, bilharzia, which is quite common in our setting, tuberculosis, and carcinomatous-associated strictures. I'll show you a subsequent slide of a fistula that I stented with a reasonable outcome. And we've also used them for PUJ obstructions as well. Okay, off the topic, but I thought this was an interesting slide and I just wanted to show it. So this patient basically had radiation, whole pelvic radiation 30 years ago for cancer of the cervix. And she subsequently developed a radiation-associated stricture between the ureter on the right-hand side and the colon. As a consequence of this, she was developing recurrent urinary tract infections and febrile urinary tract infections with pyelonephritis-like episodes, where she was necessitating admission and IV antibiotics almost on a 2-weekly basis. So after rendering a urine sterile, we considered the options, and she was a poor surgical risk. So we looked at the option of an ALLIUM stent across the fistula, which we duly inserted, and she did fairly well. She post-insertion of this stent, she didn't develop a subsequent pyelonephritis-like episode. Sadly, though, this patient eventually demised from her condition, her malignancy, 6 months after the stent was inserted. So back to the low urinary tract stenting, and once again, yeah, they say a picture says 1,000 words. So you can see here that there's a reason why the BUS has the lion's share of this picture, because I've done far more BUSs than I've done TPSs and round posterior stents. The indications for the BUSs have been strictures which require repeated ureterotomies, tight strictures, and long segment barber strictures. Okay, in the beginning, I used the 50 or the 60 millimeter stent. But since I have started to use reverse 80, and I think my preference at this point in time is that it would take a lot of convincing for me to use anything but this in the barber urethra. But I think, as a surgeon, you pretty much would develop your own pattern as you go along. The reason why I prefer the reverse 80 is that I can get right up against the sphincter with the reverse 80, and I get good stricture apposition and stricture control immediately from the barber or from the sphincter distally. The problem I have with the tapered end is that you don't always get good dilatation with a tapered portion for a stricture that's close to the sphincter. And the other issue I have is that in my hands, I've noticed that the few migrations I've had have all been with strictures close to the sphincter, where I think probably the tapered portion helped in ejecting the stent. Okay, so if you look at the equipment, the one platform system equipment, it's basically the same device for all 3 stents. And yeah, as you can see, this is my beautiful assistant priming the device here with the fluid. So this is our irrigation port. Okay, that's the channel for the lens to be inserted. This is the crimped stent portion down here. That's the trigger in our hand, the safety device, the release mechanism rather, and the safety sheet device. And this is the meatal shield that we insert into the penis before inserting the one platform system device. Okay, so I'm just going to jump into a few cases and show you a few videos as to how we insert the stent and what it looks like sort of, you know, at insertion, and what the X-rays look like as well. So the first case I'm going to go through is a 37-year-old male who underwent recurrent urothrotomies for an STI-related stricture. His issue was that he was experiencing frequent restricturing, and towards the terminal portion of, or rather before I stented him, I was carrying out optic urothrotomies on this guy on a 3-monthly basis. His stricture was a tight barber stricture, about 1 centimeter in length. He underwent an optic urothrotomy 2 weeks prior to my stent insertion. I've got a picture of the optic from that, so, but we'll go to the video of the stent insertion as well. Okay, this is the picture of the stricture look like. As you can see, it's fairly tight stricture sitting in the barber urethra. Okay, so this is at the time of insertion of the stent. This was 2 weeks after the optic, so it's already wide open, but I'm just highlighting here as to where we do the optic. So basically we make the first incision at 12 o'clock, and we want to cut to a diameter of about 28 French. You want to cut sufficiently into the fibrous tissue to the point of bleeding into healthy tissue, but you don't want to cut too deep into the healthy tissue, because too much of bleeding is not good for your stent placement. If need be, don't be afraid to turn your scope around and make incisions at 5 and 7 o'clock as well, in order to get you the 28 French diameter that you want. I'll show you that in a subsequent video. Okay, so this is our stent deployment. So we're traversing the urethra here with our one platform system with a 0-degree lens, and there's an air bubble. All right, we shook it off, and there we go, exploring the urethra. Okay, we're coming up to, we just traversed the stricture there, and we're coming up to sphincter. So this is a reverse AT that's in right now, and yeah, that's pretty much why I prefer the reverse AT. So I know that it dilates up to 45 French from the point of deployment. Okay, so at this point, when you're happy with your position, you're happy that you haven't gone beyond the sphincter, I get up as close to the sphincter as possible, and then I release the trigger mechanism, or rather I release the safety device and squeeze on the trigger mechanism until the stent detaches from the delivery device. Okay, so this is a radiographical picture of the stent after it was inserted with the OPS still in before I've removed it. And you can see a little bit of wasting across the stent there, and that's not due to a poorly performed optic. Just remember that these stents dilate up to 45 French, and we're just cutting to 28 French. So you pretty much will see this on X-ray. Okay, and this is a video of my device removal. And for whatever reason, I've got a lot of blood here. Okay, so we remove the device with gentle semicircular motions, with smooth semicircular motions without pulling too hard. If there's any resistance, you stop and you wait and you allow more time for the stent to deploy. And there we can see our sphincter, and the sphincter is closed in a good position. That's our stricture there. We've just gone beyond. And the device is coming out fairly smoothly. And you notice, and I haven't pulled out as yet. And there we go. Okay, and that's the distal portion of the stent sitting at the terminal bulba, almost penile urethra. Okay, this was an on-table urethrogram performed subsequent to that. And you can see this wide patency of our stricture there, and the stent looks in good position. That's our sphincter there. We haven't traversed the sphincter. That's just the contrast forcing it open. And we're outlining our prostatic urethra. This patient was continent after that, and he had good flows. Okay, this is a picture that I want to highlight, and this is why I prefer the reverse AT. It's like I'm right against the sphincter here, and I've got the stent dilating to 45 French from as close as possible. Okay, the second patient, show you a sequence of pictures, was a straightforward patient with a bulbar urethral stricture. These are pictures of his stricture, and you can see they're pretty much pictures of the same thing, but it's a tight bulbar stricture. He underwent a urothrotomy, cut it open to 28 French, and as always, these urothrotomies look like the dog's breakfast. You always see an irregular, scraggly portion. The important thing is that you got to pass your scope through and make sure that a 28 French goes through unobstructed and fairly smoothly before you deploy the stent. Okay, and that's a post-stent insertion radiograph showing that the stent's in good position. Okay, this patient also, the next patient also, had a tight bulbar urethral stricture, and also put in a reverse BUS, reverse AT on him. And what I wanted to demonstrate here, once again, was that we get as close to the sphincter, and this patient was also continent as well. All All right, this patient was a fairly interesting patient. He is a 65-year-old gentleman who developed a long segment bulbar stricture post brachytherapy, either from the procedure itself or the cystoscopies that he would have undergone, or possibly even the catheterization. He was undergoing repeated ureterotomies. We were a bit reluctant to offer him a urethroplasty because of the nature of the radiated tissue. And given the interval between the ureterotomies was shortening, we offered him the option of a bulbar urethral stage, which he duly accepted. If you look at this urethrogram, basically this outlines the tight stricture here. This irregular craggy bit over here is the previous ureterotomy that he had undergone, also 2 weeks prior to the stent insertion. Once again, this is my sphincter here. All right, he was continent. This is the retrograde injection opening up my sphincter, and his prostatic urethra, his long segment prostatic urethra. Okay, so the next few slides, I'm going to demonstrate the ureterotomy, and I think this should come with a disclaimer that it's probably the ugliest ureterotomy you're going to see, but I think his outcome, his result was fairly good, so we'll go through it. Sometimes you've got to operate ugly to get a good result. Okay, so this is me with my cold knife attempting to cut at 12 o'clock, and there we go, cut at 12 o'clock down to the point of bleeding. I'm not there yet, cutting the fibrous tissue. Now you can see this is a long segment stricture. It's quite narrow, so clearly I'm going to have to cut him at 5 and 7 o'clock as well. So the next video is me deciding that I'm going to, I've put this in to highlight an essential schoolboy area here. So yeah, so I've turned my scope around and I'm cutting him at 5 and 7 o'clock in order to get him to a diameter of 28 French, so we can insert the stent without any issues. Okay, so that's me attempting the 5 o'clock incision, and there we can see, yeah, there we go. This is the basic that I want to demonstrate, which I clearly omitted here. And I'll show it to you in the next slide. And I realized now was the right time to put in a guide wire across my stricture. And I think if you've got a complicated stricture, put in a guide wire before you cut, please. Don't be as brazen as I was with this patient, because you can often lose your way. And I'm going to show you here, okay, I'm not battling with ureterotomy. I'm intentionally showing you this cotton wool-like appearance. Without a guide wire in place, you can often have this kind of, you could just as well lose your lumen. So put the guide wire in early. Don't be like me. Cut at 12 o'clock in these difficult strictures, and often you have to cut at 5 and 7 o'clock as well. And if you need to cut at 5 and 7 o'clock, cut at 5 and 7 o'clock. Ultimately, it will open up to a diameter of about 28 French, and it will allow for decent passage of your 28 French cystoscopy. Okay, so this is a final picture before we inserted the stent. There's a little bit of a redundant flap here, but he was, at this stage, the scope was moving in and out unobstructed. And you can see my guide wire is still in place here. Okay, put this slide in to show you that you cut to the point of bleeding and try not to get excessive bleeding. And the reason for this is that the blood can act as a lubricant and may result in an increased chance of your stent migrating, as it doesn't really sit in or sit smoothly against the tissue. It kind of moves with the motion of the blood. Okay. All right, this was a picture of my deployment, and you can see there's fairly sort of a bit of tightness of my stent across here. But, like we mentioned initially, you're going to see a little bit of this. The important thing is you just want it to open up to at least 28 French initially, and then subsequently with further expansion of this, it will eventually open up the stricture. But you want it to open up sufficiently to be able to remove your device. Okay, so just like with the very first video I showed you, up against the sphincter with the one platform system, and you activate your trigger mechanism, and once you're in place, and you can see here, I'm against the sphincter, and you can see my stricture here as well. So this is pretty much the same way, remove it as we did the first one, with gentle semicircular motion. And yeah, like we said, if there's any resistance, you allow for sufficient time for it to dilate, and it should remove fairly smoothly if you've performed an adequate ureterotomy. Okay, this is a picture to show that we're right up against the sphincter here. And once again, this was the outcome or the end result with the reverse 80 in position. So we're right up against the sphincter. And this patient as well did fairly well post-op with the improvement in his flow rates. In fact, he was very happy. And also he was continent as well. All right, this was an on-table urethrogram. And you can see that the stricture is wide open. Once again, we have the membranous urethra here, and that's a prostatic urethra. That's the final position of his stent with contrast in, and that's pretty much where his stent lay once the contrast drained. And he had a fairly good outcome, and I was pretty happy with him. Okay, this is just a single X-ray to show you the positioning of a round posterior stent in a patient who had bladder neck contracture following brachytherapy and TURP. These stents, as we mentioned, can protrude about 0.5 centimeters into the bladder, the body traversing your contracture and a bit of the prostate or the prostatic urethra, the sphincteric portion going across your membranous urethra, and the anchor sitting in your barber urethra. Okay, if you look at a few problem-solving tips and tricks, the word migration with these stents is almost a swear word, but I think anybody who's using these stents should realize up front that migration is not a failure, and it's going to happen. The incidence, or quarter incidence from the literature, is that it happens in up to about 11% of patients. And the reason for this is a few things that we touched on. It could be that maybe we chose the wrong stent, or we've cut too deeply and there's a bit of blood, or we haven't deployed the one platform system adequately, or we tried to remove it too soon, and we've pulled the stent back with the removal of the device. So I think, if you identify what causes migration, sort of, we could obviate this by being a bit more cautious when inserting these stents. Okay, the issue of a stent coiling on itself, okay, we can obviate this by not deploying the stent too fast and making sure that we release the delivery device slowly and steadily. Okay, a stent which fails or which neglects to dilate, this usually happens because the device was not flushed. And as you saw in the video, we made sure that the device was primed before insertion of the stent. Also, and I can't emphasize this enough as well, don't remove the device too soon. Allow sufficient time for it to open. I'm not the most patient person, but even I've learned to do this. So it's difficult sometimes to sort of sit with the scope in your hand for 4 to 5 minutes and do nothing. I think you don't have a choice here. You just got to do it. Otherwise, you're going to pull the device out with you. Or other patients with infection, we should make sure that the urine is sterile before inserting it, and we should give all patients broad-spectrum antibiotics on the table prior to insertion of the stent. Okay, a patient who's incontinent post insertion of these stents, it's usually because either we've selected the wrong stent or the stent has migrated beyond the sphincter. To obviate this, I think we just need to be cautious when removing it and avoid any jerky movements. Also remember that there may just be a bit of post sort of void dribbling post insertion of the stent. And often this settles within 48 to 72 hours. So don't panic if the patient's got a little bit of dribbling. Of course, if the patient's got marked stress and urinary incontinence, that's a separate issue. But a little bit of dribbling can be acceptable and usually settles. Okay, stents, or rather another problem which maybe encounters is a stent which will not deploy. And there's a unique safety mechanism here, a plastic sheet, which allows you to separate the stent from the delivery device to sort of obviate this. Removal of the stent, we should do it at the right time and use the right grasper again to not have any issues with that. Okay, so if you look at the analysis of my outcomes, I'm just going to basically run through a summary of the baseline preoperative parameters in the patients who've undergone or underwent BOS management or BOS stricture management. The average age of these patients in my practice was 44 with a range from 27 to 72. The average stricture length was 17 millimeters with a range from 10 to 45 millimeters. The average maximum voided flow rate was 6.5 mils per second with a range of 2 to 11. The average post-void residual was 100 mils with a range from about 40 to 350, and the average IPSS score was 19 with a range of about 12 to 25. So when I compare my pre- and post-surgical parameters on factors that we use to assess obstruction on clinical and objective parameters, that's the voided flow rate, the post-void residual, and the IPSS, I found an improvement on average of the voided flow rates from 6 to 12.5 post-operatively, an improvement of the post-void residual preoperatively from 110 to 45 post-operatively, and an improvement of the IPSS from 21 to 11. Importantly, on this slide, I looked at whether this improvement was a sustained one. If you look at the preoperative sort of average maximum voided flow rate was 6, and I found that it was sustained over a period of time, although it was starting to taper off towards the end, and I think I need more follow-up on this to look at the long-term efficacy, but it was still a reasonable outcome. The post-void residual as well there was marked improvement from my baseline preoperative post-void residual. And this also was sustained over a period of time, with the few that we've had at 3-year follow-up also demonstrating significant improvement, which was durable. The adverse events which I've encountered, I had one stent migration, and that was very early on, like you mentioned, in a patient who I used, I think it was a 60 or either 50, I can't remember offhand. His stricture was about 5 millimeters from the sphincter. In retrospect, I should have probably used the reverse BUS. I've had 2 patients who gave me sleepless nights for the first 6 weeks after stent insertion, and they complained of significant urethral and perineal pain to the point where I was pulling my hair out and actually considered removing these stents. But I think with patience and reassurance of these patients, they both fortunately settled after about 6 weeks. And both these patients were infection-free as well. I had 2 patients who had immediate stress urinary incontinence. And by stress urinary incontinence, I mean proper urinary incontinence, not just a little bit of dribbling. In one of these patients, I had to actually go back a week later and pull the stent back, and he did well. The other, thank heavens for that, he settled with conservative measures on day 3 following the Kegel exercises. And I don't know, I think probably the Kegel exercises helped in probably just ejecting the stent a little and positioning it in a better place, which I didn't do up front myself. One patient presented with a recurrent stricture, and he was referred on for a successful urethroplasty. So the summary of my BUS experience, I find that these stents are fairly well tolerated. They have an acceptable complication rate. Follow-up shows subjective and objective improvement as well. So not only am I happy, but the patients are happy as well. Importantly, failure of these stents to not compromise the tissue integrity for a subsequent urethroplasty, overall they're cost effective. They minimize the need for subsequent ureterotomies and all the costs associated with that. And I think when we're looking at costs associated with the procedure, we also need to look at the cost to the patient as well, because every time they come into theater, in our setting, they're taking time off work, and often it's no work, no pay. And it results in my clinical practice in my setting. I've noticed that it results in improved quality of life. Okay, so in conclusion, and I'm going to start off by saying that surgical urethroplasty is still considered the gold standard for difficult or complex urethral stricture. And the literature's quoted success rate is about 86%. However, there are a few minor issues associated with this, largely the cost, the accessibility, the expertise, and the prolonged hospitalization associated with it, and the time required off work, which in our setting is a huge issue. So I find that the BUS ALLIUM stent is a feasible and safe treatment of recurrent urethral strictures, as it's minimally invasive, it's a viable alternative to repeated ureterotomies. It provides a definitive stricture management solution. So unlike ureterotomies, where we're sort of just managing the incident and sort of waiting for the next episode, here with remodeling of the scar tissue and remodeling in that wide open position, I found, and the sort of literature backs this up as well, that we have a durable solution here, which actually provides a stricture management solution and not just a, sort of an optimization tool. There's limited mobility associated with it and almost immediate return to work. I mean, the selected patients, they could even go back to work the next day if need be. Importantly, also in our setting as well, the ALLIUM BUS stent may or can alleviate our theater burden and reduce waiting lists. And long term, they provide to be a cost-effective solution. Right, thank you very much everybody for listening, or as we say in our part of the world, siyabonga kakhulu, and we look forward to hosting you in our part of the world pretty soon. And as you see, yeah.
Dr. Ramkissoon, thank you very much for this wonderful presentation. I think everyone will agree with me that
beautiful place. If you're here, give us a shout. You're more than welcome.
And it was really very much informative and a lot of tips and tricks we all willing to get in such an event. I have one question to you. So would you recommend to, if I make the first urethrotomy and there is a need for another, to consider the BUS stent to place?
Yeah, it's a good question. Huh? I think, you know, anything beyond a single ureterotomy, I think we're heading towards now sort of looking for a more durable and sort of a lasting solution. Because if the patient's had a stricture that's recurred once, you're cutting the same fibrous tissue. Yeah, I mean, I'm able to, you know, look into that from a study perspective. But if you ask me my opinion, if you need to go back and sort of, cut a stricture the second time, then I think you should, at the back of your mind, consider this as an option for the management of your patients.
Thank you very much for that, because I think we're talking about very important point, especially taking into consideration the backlogs and the operation room time, which is so much missing during this COVID-19 period, especially in South Africa. And that I just very much excited to record your presentation, and those who could not participate in our event, we will of course share with them the recorded file. But don't leave yet, because we prepare a quiz. As usual, we prepare a quiz for you. So, and please give me the host back, and I will have a possibility to share my screen. Just go, Dr. Ramkissoon?
Yeah.
Just give me the host, okay? For the.
Sorry, but I missed that, Maxime. Give you the?
I'm just asking to get the host back. Now you're hosting the webinar.
Oh, okay.
Click on me. I am Doron Ban, okay? So so I'm under Doron Ban. See in my picture, and and just click on more, and then you can give me the host.
There we go.
Okay. Well, so we will share with you the webinar. Just let me share the screen. And not the webinar, sorry, the quiz. No, this is not the quiz. 1 second. Okay, 1 second. Stop share. Okay. Share the screen with the quiz. Just 1 second. Can you see it?
We can see you, Maxime.
Yeah, very nice. That was not the purpose. Okay, just 1 second. This is not. I see it's open on my PC, but I apologize for that. But give me just a couple of seconds to fix it. And yeah, it is here. Okay, so now you should see it. You see it? Yeah?
Yeah, we can see it.
Yeah, I can see ALLIUM webinar class 2, Dr. BOS class 2. It in fact should be class 1, but okay, so you see the first question?
No, Maxime, this is number 2, because number 1 was with La Fe Hospital from Valencia last month.
Yeah, correct, right. Okay, so Doron, you want to go through the quiz, or I will do it?
I give you the honor to do it.
Thank you very much. So, everybody, the first question. When the stent is fully expanded, the diameter of the stent is? I want to see you.
In the meantime, you can unmute yourself and shout the question or write it in the chat box.
You can also answer it loudly, or you can just write it down, you know, on our chat. Okay, I cannot see the chat.
Number 2, the answer is.
Thank you very much. Near number 2, 45 French. Okay, all ALLIUM OPS stent I deployed to the size of 45 French. The dilation of stenotic area should be at least up to, okay? What will be the answer?
Number 4.
Number 4. Okay, number 4 is the correct answer. At least 20. We recommend to dilate it between 26 to 28, but at least it should be dilated into 26. Chaillet, as Dr. Niemeyer said, of French, we call it. Okay, what is the ideally dilation method we recommend? Yeah, I cannot see the chat, unfortunately, but okay, so we recommend to make it urethrotomy or cold knife, okay? Which is the following optic element brands can be used together with the OPS?
Maxim, you need to go back to the quiz.
You cannot see the quiz?
No, we can see a slide.
Got a slide of yours on, Maxim.
Okay, so let me put it here. Now you see the quiz?
Yes.
Okay. Because I'm working with two screens, it's a little bit challenging, okay?
Technology.
Yeah. So what are the following optical elements? Olympus, Karl Stolz, Richard Wolff, or all the above? Louis knows the answer, okay? But she's on mute. So
All of the above.
quite reasonable, okay? It's a universal device. What is the diameter of the OPS delivery system? The answer number one, 10 French. The answer number two, 22 French, 24 French, or 24 2 or 24 French.
Number 4, for BUS it's 22 French, and for TPS and RPS it's 24 French.
Here you are just an excellent student, okay, well done. Well, what is recommended if after the full squeezing of the trigger, okay, so full squeezing of the trigger, okay, the BUS stent is not deployed. What you do? Answer number one, press the trigger additional 3-5 times. Or the system is faulty, we need to use another OPS instead. Number three, the stent protruded into the sphincter and need to be repositioned. And number four, the secondary deployment mechanism, Teflon sheet, pull bottom should be pulled out. Okay? Near?
Number 4.
I just told you don't answer. Okay, so of course, number 4, we have a secondary deployed mechanism. Once the trigger is stuck, so we push the pull button, and there is a knife inside, and it's cut the Teflon, and that stent then could be deployed. How to measure the stenosis rate? Measuring tape on cystoscope. Number 2, by ureteral catheter. Number 3, contrast media by X-ray. And number 4, all the above.
Number 4.
Thank you very much. Number 4, all the above. If the stricture is 1 centimeter and located 4 centimeters away from the external sphincter, which BUS stent should be chosen? Answer number 1, BUS 80 millimeter. Answer number 2, BUS 80 millimeter reverse. Answer number 3, 50 millimeter. And answer number 4, TPS plus 40.
Number 2, the answer is?
Yes. First of all, Dr. Ramkissoon by far will choose BUS 80 millimeter, but somehow the answer coincides with our agenda, because if stricture is located 4 centimeters out of the sphincter, there is no use of the sphincteric pad. The maximum length of the stent is 80 millimeter. So in this case, we will go for reverse, okay? And you have, for your convenience, our table. We provided you with our newsletter how to measure the appropriate stent size and what the stent we choose for different types of stricture and the distance of stenosis from the sphincter, which are necessary before the stent BUS implantation. Answer number 1, antibiotics 3 hours before the procedure. Now, answer number 2, precise measurement of the stricture and the distance from the external sphincter. Answer number 3, dilation to at least 26 French. And answer number 4, all the above. Near?
The answer is number 4, all of the above.
That means silence, okay? That's let somebody, someone else to. Okay. So far, Nir is our excellent student. So 10, if the stricture is 7 centimeters long, which stent should be chosen? It's a tricky one, okay? So the one is BUS 80 millimeter. The 2 is BUS 80 millimeter reverse. The 3 stent cannot be implanted. And number 4, stent 80 millimeter plus 50 millimeter. What is the answer? Okay, I will need to explain it. Look at the BUS stent, okay?
The tricky one, Maxim.
The stricture is long, the stricture is 7 millimeter, okay? 2 sides of the stents are soft, okay? They cannot be used for the stricture. So what remains us with, I always say, take the BUS stent, the longest -3. So -3 from 8 centimeter will be 5 centimeter. So we will need consecutive stent. We will need stent and stent construction. Did you implant it, by the way, stent and stent, Dr. Ramkissoon?
No, I haven't, but apparently Louise said there's a surgeon who's planning on doing one. I'm hoping it works out because I'm keen to see how that goes with the stent attached to a stent, yeah. But I haven't done it myself, yeah.
For URS, we have such a possibility, which we like to introduce, but also for BUS, this possibility is existing, so we can make consecutive stent construction. And of course, the answer will be number 4. Okay, so we will use 2 stents, one into another with 2 centimeter overlap, 80 millimeter plus 50 millimeter. Now to cover all the entire structure. Okay, so you have a link for the quiz, so please feel free to send it to all your appropriate person, and you can fill your details and send the result for us. Okay, and just we will receive the result anyway once you fill the details. Okay, so basically we have done. I think Duron, a couple of words from your side.
Yeah, I want to thank, first of all, Dr. Ramkissoon for the very interesting presentation and sharing with us his experience. I'm sure it will be helpful and useful for our users and distributors. And we will keep update with you about the next procedures. We will be happy to invite you again and hear from you your experience about TPS and RPS as well.
Thanks. Thanks, John. Thanks, Maxime, as well. And, like I said, we mentioned this up front as well. I mean, I think in our setting, these stents have a huge role to play. And we're certainly not pushing or advocating that it be first-line treatment. But I think if you look at all the added benefits that come with it, and I think this is the take-home message that, I want to leave our guests with, is that, it's an efficient sort of way of managing our patients. They come in, they go home pretty much the same day or the next day. They're back at work as quick as possible as well. It's a cost-effective way of managing these patients. It reduces the burden in our theaters. And it's a long-term stent solution. It's not just, like a urothrotomy, just cutting it, waiting for it to happen again. So, yeah, it's something that probably will take off more and more here with the more awareness being created around it. Because, I think we pretty much, at this point in time, are still doing quite a few urothrotomies in our setting. And also, urethroplasties, I'm not sure what the worldwide trend is like, but yeah, they should really be done in a center of excellence. We've got them few and far between here. So yeah, thanks for asking me to speak and sharing my experience. It's been a pleasure. It's been an honor to actually share with you guys. And I'm hoping the next time we chat, this experience will have grown and yeah, we can add to this.
Dr. Ramkissoon, thank you very much for the presentation. I've just got a quick question for you, please. In your experience, do you usually use the suprapubic catheter? And if yes, at what time of the procedure?
That is a fantastic question. And I'm going to answer that by saying that I don't routinely do it. But in patients in whom I've identified this kind of dysfunctional voiding pattern, especially guys like, I would consider it in the round posterior stent and the TPS stent a bit more than the BUS stents. Guys who've got this hostile bladder or have had this prolonged obstruction, I would consider it more in them, largely because they're at risk for sort of ejecting that. So I kind of individualize my patients. I don't routinely use it. I think if the guy's got a short segment stricture, is recurred once, and the bladder thickness doesn't look like a hostile bladder, then I wouldn't routinely put in a suprapubic. But if you recall the video that I showed you, the one with the guy who was post-brachytherapy, I mean, he's had this prolonged obstruction. It was a long segment stricture. He had prostatic issues as well. So he certainly had a suprapubic catheter put in. So yeah, I kind of would put it in a patient in whom I think has a hostile bladder. I hope that answers your question.
Thank you very much. You did.
You're not only excellent with answering the question, but also asking very good questions. So I could only conclude that Dr. Ramkissoon, I'm very happy to have you on board, and thank you very much for being with us. And it's a big honor and pleasure to have you with us. And we definitely will continue our sessions. And thank you very much for everything.
Thank you very much, Doctor.
Pleasure. Thank you very much.
Okay, so everybody, thank you for joining us, and I wish you a great weekend, and goodbye.
Thank you.
Bye.
Bye.